Well, good afternoon, everyone, and welcome to our webinar. This is Lauren Rabinowitz with the Center for Excellence, and we are really excited about our presentation this afternoon on connecting mental health consultation data to program outcomes and financing. Really appreciate you taking time out of your day to join us. And this is our standard disclaimer slide. So SAMHSA is the funder of the Center for Excellence, but we want to remind everyone that the views, opinions, and content that is going to be discussed during this webinar today is the views, opinions, and content of the presenters. We have an esteemed panel of subject matter experts that are going to be speaking to you today on a variety of topics. I'm going to do a quick introduction of each now, just so we don't interrupt the flow of when they are speaking. So we will first hear from Deborah Perry. She is the Director of Research and Evaluation and a professor at the Georgetown University Center for Child and Human Development. In this role, Dr. Perry provides leadership on a broad portfolio of applied research and rigorous program evaluation. Dr. Perry's research focuses on approaches to designing and testing preventive interventions for low-income young children and their caregivers. She has helped establish the evidence base for the effectiveness of early childhood mental health consultation in early childhood settings. She has co-authored more than a dozen peer-reviewed papers on mental health consultation and has served as the principal investigator for 4 evaluations of mental health consultation programs in Maryland and Washington, D.C. over the last 15 years. You will then have the pleasure of hearing from Steve O'Connor. He is a licensed marriage and family therapist with a master's in somatic psychotherapy. He is currently the branch chief of prevention and early intervention services and the program manager of Healthy Futures at the DC Department of Behavioral Health. Steve has been with Healthy Futures since its inception and was an early childhood mental health consultant for the first 6 years of the program. Steve has worked with children and young adults for over 30 years as a therapist, director of Turning Point for homeless young adults, and as a high school teacher. And finally, you will hear from Valerie Alloy. Dr. Alloy is a behavioral health policy administrator, educator, researcher, and clinical practitioner. She joined the Ohio Department of Mental Health and Addiction Services in February of 2013 as the Mental Health Administrator in the Office of Children, Families, and Prevention. She currently leads the department's Early Childhood Mental Health Initiatives and is appointed to the Governor's Early Childhood Advisory Committee and the State Cross-Agency Early Childhood Leadership Team. Prior to joining the Ohio Department of Mental Health and Addiction Services, she served in the Department of Youth Services as a member of the Psychology Department, working with the most violent and dangerous youth offenders. Dr. Alloy is a licensed supervising clinician, clinical psychology fellow. She is a champion and advocate for youth and lifelong learning and promotes the use of scientifically validated, evidence-based practices for systems and individual change. So those are your speakers, and you all are in for a treat to hear their collective knowledge. Here are our learning objectives. We're hoping that you will come away from this webinar with a better sense of how to use evaluation and performance monitoring data to tell the story of infant and early childhood mental health consultation. We know it is a complicated field. There's lots of pieces, and having that as a tool in your tool belt is an important one. And to build on that, to understand how these types of data can lead to sustainable funding. And finally, knowing the basic terminology and the different types of mental health consultation evaluation tools will just further those skill sets. All right, so without further ado, I'm going to turn the first section of the call over to Deborah Perry. Take it away. Thanks so much.
Thanks so much, Lauren. I get the task of just kind of making sure that we're all starting from the same page and kind of setting up these 2 amazing speakers who are going to share very concretely how 2 systems have gone about collecting data, integrating data into their ongoing programming, implementation, and monitoring, and then also looking at outcomes and using those outcomes to expand services to their population. So I am just going to really go quickly through some basic stuff To begin with, as somebody who does a lot of community-based program evaluation, I always want to start with a theory of change. Theory of change is a somewhat fancy way to say that we want to articulate how we think our intervention is changing what specific things on the way towards getting to outcomes. And this particular theory of change that's on this slide was developed with a group of folks called the RAIN group, which is a group of programs who do mostly mental health consultation in early care and education, but not exclusively. A group of people who have been meeting together to kind of think together about implementation, evaluation, and policy. And so at a RAIN group meeting a couple of years ago, we really worked together to try to articulate what the theory of change is for mental health consultation in early care and education. And some of these things cross over into home visiting and other settings, but for the purposes of this webinar today, we're really focused on early care and education. And I think what we want to think about is the fact that there are both the consultant and the consultee bring into the relationship certain attributes, experience, and training that they've had. And those things form the basis of the relationship, which we know is such a critical aspect of mental health consultation work. You can see in the next sort of larger box, we have a couple of words here, attunement and relationships, really paying attention to the fact that when the consultant and the consultee are in an attuned, supportive relationship, that is the magic of the work. We have in that box also kind of what happens, like the actual day-to-day work of mental health consultation, something that we've started calling the consultative alliance, which is that very similar to the therapeutic alliance that forms during a mental health intervention. Consultants often use reflective questioning, and we talk a lot about the parallel process in infant mental health work. And the consultant often creates a holding environment for that consultee and often speaks for others. And some of these things are directly from the consultative stance that Khadijah Johnson articulated in her book. And around the outside you see here is reflective supervision. And we really see reflective supervision as a non-negotiable in good mental health consultation. It allows the consultant to have that space to do their work so that they can be with the consultee who can then, in that parallel process, be with the teacher, parent, home visitor, whomever. We think that all of that is where the consultation work happens, and that leads to changes in the consultee's thoughts, feelings, belief, and knowledge, which then in turn affects how they behave and how they are in their relationships. And those in turn lead to changes in classrooms and program level outcomes, which again lead to child and family level outcomes in an early care and education model. So this theory of change is just one example of how you might do this work in your own program. It's fairly general, but also was trying to be illustrative about the level of detail that we're looking for when we articulate a theory of change, because the theory of change really can drive both how you evaluate your work, what measurement tools you use, how you train folks to do your work. And I think all of these you're going to hear in the presentations that are going to follow. A lot of people get confused about how a theory of change is different than a logic model. And if you saw the way we laid out that theory of change in the prior slide, it does have a lot of resemblance to a logic model. I think about the relationship between a theory of change and the logic model as the theory of change is actually the arrows in between the boxes on a logic model. And logic models almost always articulate what the program's purpose is, what these processes and outcomes are. They sometimes will articulate sort of the context or basic assumptions, also usually articulate the target population and the services. I think logic models are very helpful in taking your theory of change and kind of creating something that can serve as an evaluation tool or template. Often funders request a logic model in your applications, and I think logic models are most powerful when the program folks and the evaluation folks are in the same room together, co-creating that. So as an evaluator, I never want to do a logic model in my office and then come out to my program partners and present my logic model. It's always an activity that I do with the program folks. And often I start at the end with sort of what is it that you're hoping to accomplish through your mental health consultation, and then work backwards. And we do have some really nice tools on the toolbox that's on SAMHSA's webpage that walk through some of this logic model and theory of change work in more depth if this is kind of where you'd like to dig in a little more. We also wanted to just touch on a little bit about sort of evaluation methods. Almost always when I'm doing evaluation work, I am doing a mixed methods evaluation, which means that I'm gathering qualitative and quantitative data. There are certain kinds of questions that are best answered only with qualitative data, and these are some of the things where we don't have great validated tools, but we know that the construct is super important. I'll pull out just for an example the idea that I shared a few minutes ago about the consultative alliance. We think that that is an essential feature of the work between a mental health consultant and the consultee, but we don't have a great set of tools to really measure the consultative alliance well. We have some data that folks have gathered in some studies, but not a validated tool. When we're doing qualitative work, we can really articulate more fully some of those important constructs and measure them in that way. With quantitative data, it's really important. Some of the ongoing questions right now in the field are really about dosage. So how often consultants are there, what's the duration that we need in terms of the engagement of the consultant with the consultee, and some of those things can be captured through activity logs. I think we also rely on pre and post measures, which you'll see in the Ohio work very in a lot of detail about whether we're asking parents or teachers to report on children's behavior. And just to remind people that it's almost always the case that we want to be doing process evaluation, which is really evaluating the implementation of your program as well as outcome evaluation. Just a couple of more details about measures and measurements. A lot of folks, when they're starting their mental health consultation work, are motivated to improve child-level outcomes. If you remember from the theory of change, child-level outcomes are the furthest at the end on the right side, which is after all the other changes have happened, then we expect those to result in changes at the child level, because mental health consultation is an indirect approach. But that's often what motivates people to fund mental health consultation programs. So I think as evaluators, we're always kind of in a little bit of a pickle about that. And there are, fortunately, a lot of good measures of child-level outcomes, whether it's social, emotional, behavioral, and importantly, making sure that when we're choosing evaluation tools that we're being very strengths-based and looking at pro-social skills. We also know that important variables such as parent-teacher-child relationships and what's happening at the teacher level, teacher-child relationships, and the classroom climate are all super important in terms of domains to measure. So a few more slides just articulating different kinds of outcomes of interest. Here we see a few different things that might be measured at the teacher or home visitor level, such as stress or burnout. Turnover in early care and education is something that we looked at with our Healthy Futures partners, so Stephen may touch on that. And the fact that there's lots of different ways to collect each of these kinds of variables. Most often with the classroom environment, we're doing observations, With child behaviors, it's less often the case that we're doing observations, but we usually rely on caregiver or teacher reports. And then with provider stress, a lot of different opportunities to think about how mental health consultation might impact that. And finally, just wanting to clarify that it's very important, no matter what the size and scope of your program is, that you're thinking about how you integrate evaluation tools into your ongoing program implementation. It's not often the case that you get to have funding for an external evaluation. When you do, it's super important that you partner with that external evaluator, but it's also really important in an ongoing way that you're measuring how is the model being implemented the way you intended, and how well is it happening. And that sort of ongoing monitoring and evaluation is similar to but different from what happens when you're doing external program evaluation. And often there's a nice interplay with that, which I think, again, you'll hear in the examples. So in summary, everybody should care about program evaluation. Evaluation is how we tell our story, and it's really important to start with a theory of change and a logic model to guide your work. Lauren?
Thank you so much, Deborah, for going over that. It's always impressive to me to hear you talk because you cover so much information and you make it sound really achievable and doable. And I love that because I think that's really the message that we're trying to send here, that evaluation is, and in looking at your data, it's not optional. It's part of the work, but it is doable, despite a lot of the challenges that, the folks were reporting on in the beginning, but we're still going to make it happen. Thank you for that really comprehensive overview. And I'm excited to now have Steve O'Connor from the DC Department of Behavioral Health talk to us about his work with the Healthy Futures program. Thank you so much, Steve.
Thank you, Lauren. It's a pleasure to be here. Just to give a very brief program overview, right now, Healthy Futures, we are 7 consultants, and we are in a total of 61 sites. So that's 42 early care and education centers and 19 home providers. And we're also currently serving every district in Washington. But not all of the centers are covered. So roughly there are about 450 centers and homes in the district. So we have a long way to go. Some of the consultation activities are listed here. Right now, we're currently seeing a lot of prevention and early intervention activities, so the consultants are doing a lot of that work in the classrooms as well as modeling. So they're modeling how best to respond to challenging behaviors, how to do a good circle time, how to perform good transitions. So these are the big ones that we're seeing right now. And here's a list of some of the data collection categories that we have for our monthly report. And so for our monthly report, we're collecting data specific to that month, but we're also keeping a running list of important totals. For example, we will collect, say, the number of children that were referred to us for that month, but also keep an update of total number of referrals for easy reference. And we also break down our data per consultant and center. And we look for trends in the center data to inform the consultants' weekly check-ins with the directors and also our leadership team quarterly check-ins. We're really looking for any trends that stand out. One of the things that we notice, a big trend that we see, some of the centers either refer a lot of children to us or no children to us. And since we really want to focus on the children and the families, we're really curious when we see no referrals from a center. So that's something that within the relationship between the consultant and the director, they can speak about. And then when we contact the directors quarterly, we can also speak to them about that. So the evolution of our data collection, when we began 10 years ago, we had a list of data categories for consultation. And so we were curious to see where we were using most of our time. But some of the categories as we were going forward became a little confusing. For example, we started collecting data on how many meetings that we were conducting. And part of that was the meetings actually became confusing because we had some meetings that we were holding, some meetings that the center held that we were being invited to. So we really decided that because of this and because it was difficult to track and that we felt like it wasn't an apparent high priority data point, that we kind of put collecting data on meetings to the side. One of the things that we really were focused on was parent consultation. So at first, we only captured consultation with parents whose child were on the consultant's caseload. So anybody that we had consent to work with. But we noticed in our work that a lot of parents were stopping consultants just to ask basic questions, and we weren't at first capturing that data. So we decided to open up that capture, and we decided to any parent consultation, whether it was child specific or in passing, we decided to begin to capture. We also began to notice that we were doing a lot of phone consultation with parents that we weren't capturing. So we now have two categories, one for face-to-face and also one for phone consultation. And along with that, we decided to start using a child-specific chart to help us keep track of the children that we were doing direct consultation with. And over the years, we decided that it was better data for us to actually track the number of referrals rather than the number of consents, because it seemed like we had more control over the number of referrals. And that goes back to our conversations with the directors. So now at DBH, we're building a platform in QuickBase, and this is really helpful for the consultants to actually enter data in real time. And I think time is the greatest challenge in data collection. Our consultants are going to between 5 and 8 sites a week, and a lot of our sites are half-day sites. The time that the consultants have in actually doing any kind of paperwork or inputting data, whether it's an activity sheet or into QuickBase, is limited. We try to give them the tools necessary to have them be able to do that during the day. So besides the laptops that they have, they also have tablets. We give them hotspots. And we're also looking at the centers to make sure that they have a space in each center where they could go if they need to. And that's tricky because a lot of the centers don't have that space for the consultant to go and have a quiet moment. But we give them those tools because we know if they can actually enter the data in real time in QuickBase, we can see it if we need to have running totals. But it also lets them do the data while it's fresh rather than waiting until Friday when they have office time. So we expanded in year 6, and that was mostly due to the good word on the street for Healthy Futures and also the strong data. And we were also working in partnership with Georgetown for the first 4 years of the program, and we had beautiful comprehensive reports from Georgetown. And from that and just the good reputation, we were asked by the Office of the State Superintendent of Education here in DC to help them with 2 initiatives that they have. We grew from working in 26 sites to 46. We're now in 61 sites, and we're now working a lot with more government and community partners. So they're most interested in knowing, say, how many teachers receive coaching, as they call it, and also how many children and families receive services. So they want to really see the impact we're having in the community. They're most looking at how many children are screened, how many receive child-specific consultation, how many are referred to outside mental health services, and how many family workshops we conduct. And just a few quick points about this. We began actually using the Strengths and Difficulties questionnaire when we first began the program, when we were still partnered with Georgetown. And in doing the SDQ, we realized that we really were focusing on that first part of the SDQ when we were just talking about the children in the classroom. And we found this to be extremely helpful for us. So we decided to just focus on that first part of the FTQ. And we would do a pre-post in the beginning of the year. We would sit down with the teaching team. This would be late September, early October. And we would talk about each of the children in the classroom. And we would listen to the teachers really talk about what they were observing, what their feelings were about the teacher. Oftentimes they would talk about their feelings towards the parents as well. But it gave us a really great understanding of not just the children who there might be concerns about, but also about the teachers and what their feelings and thoughts were about the children. So it really helped inform us how to create a relevant implementation plan and also a more specific classroom plan for those teachers. And really the last point is that we're always discussing with our government and community partners about the low number of referrals to outside mental health services. And this is something that when we report out, the numbers happen to be very low. They always ask us why we're not referring to mental health services for the children. One of the obstacles, of course, we find in the district is that there really aren't many places to refer. And then the barriers are the wait list and also for parents to be able to get to the site. But really, I think the number is so low because even though we're not providing a direct service, what we do is therapeutic. And I think often because our services are mental health services, that because of us, we don't need to refer to an outside mental health agency. So also here at DBH a couple of years ago, we began a results-based accountability process, an RBA process, and that was to strengthen our data collection so we could tell a fuller story about who we're serving and how well we're serving them. And we decided to bring back this teacher stress survey, which is something that we had done in the beginning of the program with Georgetown, and also to create a pre-post assessment of teacher knowledge on social emotional development. We're looking at that teacher stress survey because we realize how stressful the job is. We really want to see the impact that we're having on the teachers. One of our core workshops is on self-care, and we do practice that reflective supervision piece with our work with the teachers. So we're really curious to bring that back and see the impact that we're having on teachers directly with our work. But also, during the course of a school year, we're really doing a lot of work on educating teachers on social emotional development and best responses to challenging behaviors. So we wanted to start to capture how much the teachers know when we first come in, and then how that changes over time with our being in the classroom, talking about certain things, certain behaviors with children, and also the workshops that we do. The leadership team here is also making a point to visit each of the centers to help sustain the relationship and to discuss the program. And it's at that point that we ask the director to actually fill out the director survey. And we have done that now every year for 10 years. And we always get good responses from the directors, but it's always nice to have that type of data to really be able to tell the story as well as strong quantitative data. Really, with our collaboration in the beginning with Georgetown, with our collaboration with the directors and the teachers and the families at the center, we have built a really good relationship in the community, and we've really worked hard to have the data to back that up to show the city the impact that we're having. And that will do it for me.
Steve, thank you so much for sharing all of that information. Again, I'm just amazed at the progress that you all have made, and now you have grown that program so tremendously and have so successfully used all these different evaluation tools to support that growth. So that is really exciting. I'm so glad you've had a chance to share that. And we are now going to turn it over to Valerie, who is going to share the incredibly exciting information from the statewide program in Ohio and all the fantastic work that they are doing with mental health consultation. So Valerie, we are super excited to hear what you have to say.
All right. Well, hello, everyone. Ohio is so excited to join the webinar to share the work that we've been able to accomplish really historically for a while, but certainly now as it relates to our most recent history. One thing that we want to talk about is our state snapshot. So Ohio has received funding from our governor's office to expand the early childhood mental health program. We build that on a background of success. Prior to my joining the department, in 2009, we had a smaller pilot of early childhood mental health consultation and had a program evaluation component around that. Based upon our ability to show that early childhood mental health works, we were then able to do an expansion. We also are building on the success of our Early Learning Challenge grant, which brought together most of the child-serving state agencies into several focus areas. Obviously, getting children enrolled in high-quality preschool was one of the biggest areas, but it also involved what I call the sister agencies to provide supportive services to children and teachers and families in those classrooms. So our program is an outbuild of those two major historical events in our state. So fast forward a little bit, 2016-17, as our Race to the Top Early Learning Challenge grant was winding down, we wanted to know how do we sustain some of the inroads that we've made. And it was at that time that we talked about building in more what I call boots on the ground in early learning settings. To that question and response, our governor's office did fund our program at the $5 million level per year, offering us a $10 million biennium budget exclusively for early childhood mental health consultation. We now find ourselves in the position of having developed a statewide response. The map that I'm showing now is Ohio in all of its 88 counties, and the color coding shows the incredible collaboration that it requires at the ground level to build up an infrastructure of our size. The color codes also correspond to an interactive map that lives on the Ohio Department of Mental Health and Addiction Services website. A family or provider or early learning center, if they wanted to know who was their local provider, they would toggle over their county area and they would receive a pop-out of the program and the phone number and how to get in touch with the early childhood mental health consultant. The other thing I want to mention while we're looking at this map is another part of our program, which is our 24-hour preschool expulsion prevention hotline. That program can receive a call via the internet or the telephone, and we will triage that call and send a consultant out physically to any of the early learning centers that are within our state catchment areas. And then those respondees are coming from these behavioral health agencies that are shown across the color-coded map. So our program is a pretty traditional program, and I would like to say that we strive towards model fidelity. So our program, again, is an indirect service. We have our logic model, but what we were really looking at in Ohio is how do we get to some of the short and long-term outcomes. So some of the things in our logic model that were important to us as we looked at the different components of the program, we have a logic model that is aligned with our classroom-focused consultation. We have a separate logic model aligned with our child-focused consultation. And in Ohio, we also do a big piece of our models around training. We found that the professional development and support really coming out of that Race to the Top grant is something that our centers really wanted. They need that type of assistance around issues of managing challenging behavior, around classroom strategies and transitions, around social-emotional development standards, around cultural and linguistic competency. So Ohio has a large menu of professional development training that are available to all of our early learning professionals around the state free of charge through our centralized registry. We had a logic model around training because also we want to look at our activities, outputs, short and long-term outcomes. As we built up this program, I was lucky enough to have a program evaluation partner, and we continued that relationship as we moved into the build-up. So Ohio has an electronic data collection system along with management and reporting, and we evaluate our programmatic outcomes for the basic components of our program: center-based, child-family consultation, and training. I think that's unique. I will say that we do have a healthy investment with our external evaluator. But I've also been advised from national experts like Deb that we could afford to invest more. So that's one of the takeaways that I want everyone to know is you need to plan to invest in your program evaluation. When we look at what Ohio is counting and measuring and paying attention to, our evaluation initiatives and activities include several measures. We are very fond of our Deborah suite, the Deborah Early Learning Assessment. Within that is embedded a reflective checklist for the environment. We are also married to understanding how are we doing with moving centers along their quality rating. In Ohio, it's called Step Up to Quality. And so we're very invested in our state's legislative goals to move most of our centers into quality, and that's why our program receives such robust funding. Tied to any part of our service, we do both a satisfaction survey. So in addition to our pre and post measures across the DECA, we also have satisfaction surveys that we get across training as well as the other programmatic areas. And then another exciting thing happening for us is our partnership with Yale, the Yale Child Study Center. We now have a randomized control study throughout our entire state offering 52 centers, services, new centers to our program around 24 counties. And we're very excited to see what the Yale study is going to say about the efficacy of our program and help us to look at areas that we can continue to grow and refine. So in terms of the outcomes, we have been able to, with our statewide workforce, serve over 24,000 children. Of those 24,000 children, we scale the type of services that they get. We have approximately 7 visits as our threshold when we talk about dosing, but some centers receive much more. But in the centers that we have been able to retain 99% of the children. And that's the big takeaway that I want in terms of our national lens. Infant early childhood mental health works. It really works, and we are able to keep children in their classrooms. We've provided consultation in over 1,700 classrooms to over 5,119 teachers. And that training component alone has trained over 15,000 early learning and community professionals. And we have a high demand for our training. We have a workforce of what we call master trainers, 8 of whom who are dedicated to training, but many of our consultants will do training at the center and the site as well. And that's one way we find ourselves sharing the technology so that people can get aspects of the program so they don't have to wait necessarily for a consultant to come in. Another thing that Ohio has been able to see are statistically significant changes in all areas of the within-child protective factors on the DECA instruments. Initiative, self-control, attachment, and seeing decreases in behavioral concern. And so those are very important. I'll call those granular level changes and child level outcome changes because that then drives where the system goes. We know that our indirect service, because we provide our consultation to our teachers in the classrooms, but when we look at what's going on with our children, the teachers are able to report as well as the families these types of changes. So just to round out a little more around our child-focused consultation activity, one of the things that we've been studying is the idea of dosage. And so since the implementation of the program, the state didn't want to dictate how many sessions a consultant might provide in a center. We actually wanted to gather the data and then see what it takes to receive those types of results. So what we found in state fiscal year 17 and 18, that consultants were spending on average 17 to 19 visits in a classroom. But our data also showed us that after the 7th or 8th visit is when we saw the change. So moving forward, that's one of the pieces that we're looking at in terms of dosing. We're going to make recommendations that after those 7 or 8 visits that a consultant consider moving on, provided their work is done. But being a clinician, one of the things that's very important for me at the state is not to dictate how things happen on the ground, and that I don't want an artificial constraint that says, oh, it's 7 sessions, you have to stop. No, if your work isn't done, stay with that teacher, that family, that classroom until the work is done. And that's an important value of our system. The other thing we've noticed is that when children and classrooms need more help, we wind up writing that intervention action plan. And we looked at the implementation of that action plan, and we found that at closure, if they were 70% implemented, that became another indicator for us that was correlated with the type of changes. So one of the things we can do with this continuous quality feedback is to look at how well are those action plans being attended to, and then can we go back to those and know if those are also helping to guide our practice. The next slide talks about our parent work. I mentioned that we are an indirect service. However, in some of the child work, we must tie communication and involve parents clearly. And that one of the things we are really thrilled to see is that for the parents that fill out the measures, and it's very hard to get our T-TAIL test closed with parent feedback, but that's a whole nother conversation about how you collect data and get it back in. But our parents have also talked about the changes that they see in their children. And as we looked at our measures again on our DECA suite, we found statistically significant improvement by parent report on initiative, self-control, attachment, which are the protective factors. In 18, our practice was more refined, and we also then saw statistically significant improvement on the behavioral concerns as well. So that was an area based on our 17 data. We took more time to work with parents around managing challenging behavior and getting them more tools to help see the results from home, stay, and classroom. And so really from a systems point of view, we know that the bedrock of development happens in families. And so for us to be able to begin to see that the work is really affecting the parents' ability to have better self-efficacy with their children is truly the icing on the cake. And for me, it's one of the hearts of the matter. So we're very happy that we are seeing some results that can continue to guide and improve our practice. Our next slide is really what our webinar is all about, and it's tying data to outcomes and financing. We are thrilled that we have emerged as a national leader in our infant early childhood mental health investments. We have a total of 129 consultants in our statewide registry. However, 77 are funded through that $5 million allocation from our state. Those dollars allow us to do this practice in a prevention model. We're not tied to Medicaid or deliverables per se. With our Medicaid redesign, some of our agencies have had to marry some of the consultants to tighter caseload and output, but by and large, these are dollars that are funded through our general revenue fund and our casino operator dollars that allow us to work untethered in what we need to do. We also see dollars coming in from local levies, United Way, Head Start and Early Head Start, and I'm hoping to see things coming in through McVie and home visiting in the future. So we have that coverage, as you saw on our map, in all 88 counties, and I talked already about the 48-hour in-person response call line. So that's the basic buckets of what we do. So when we think about how did Ohio get here, we got here through many foundational efforts. One thing I want to they are not in chronological order, but if I were to reorder them, I would say begin thinking about a small pilot. Whatever dollars and funds you can muster, focus on a small pilot and tie some program evaluation to that. The next thing that I would say for us was tie ourselves to larger grants. And so we had the Race to the Top Early Learning Challenge grant, which really catapulted us. And then we learned to tell our story. So the write-up in the My Brother's Keepers report, the White House report of our previous administration, also helped people to understand what we're doing. It's important to have a registry of consultants, so to be able to pool and understand their credentialing process and have as much conformity as possible to your practice. And then for us, I would say we would not be here if it were not for our external statewide database and program evaluation effort. So hopefully that gives you all a flavor of what we've been able to do.
Valerie, thank you so much for sharing all of that information. I know we gave each of you a very tricky task to talk about decades of work in a very short period of time. So thank you so much for going over all that information. We all know that this is individualized work, so hopefully you can take lessons learned from DC and Ohio and apply it to your own state or tribe or community. There's a lot here, and certainly don't want anyone to leave thinking that the answer is just to necessarily pick up exactly how DC and Ohio have done their programs. We look forward to continuing the conversation with you. Thank you so much for joining. Thank you so much to Deborah, Steve, and Valerie for taking time to share your expertise, and thank you to everyone. Have a wonderful rest of your day.